All right, boy, two great talks here. So, what I want to share with you is what our experience has been with vertebral body tethering. These are my disclosures, the most notable of which for this talk is I do receive royalties on the tether product. One of the main messages I want to get across is, firstly, listen, posterior spinal fusion is the gold standard, okay? I mean, there's no ifs, ands, or buts about this. We have gotten much better over the last 5, 10, 15 years in how we perform fusions. Our neuromonitoring, our implants, and this remains the gold standard. But we need to have options, right? I mean, if you have a child who has a curve that you see up here, there's a certain subset of these kids that will end up doing better with a fusion. But there may be another subset that do better with a growth modulation, a motion sparing procedure of vertebral body tethering. I loved Dan's comments a little bit earlier on how he, when he's consenting the patients for arthroplasty versus fusion and how he lays out both of the options, because that is certainly a very relevant question here for us. So, vertebral body tethering is not our first attempt at growth modulation where we are trying to inhibit growth on the convexity of the curve, allowing the concavity to catch up. At the Philadelphia Shrine, my mentor, Dr. Randall Betts, had a long-standing history of vertebral body stapling that was done between about 2004 and 2008 at our hospital. Unfortunately, what we saw was there were a significant number of patients that ended up failing vertebral body stapling. They come in for curves that are 35, 40 degrees. Initially, they may look good, but at the end of a year, 2 years, 3 years, they were ending up having fusion done. We looked at our data at this, but when it really struck home was when I started having my colleagues from around the country. I'd have some, Dan Ciccato, I remember calling and say, hey, listen, you guys did a staple, I'm fusing this child, do you have any tips? That's when we knew we had to really very critically look at the data, and we've pretty much abandoned that procedure, vertebral body stapling, in around 2012 or so, because we also recognized that bracing was really, from the brace trial, was efficacious in a very similar patient cohort. Can you guys hear me okay? The stand is just in the way, so I just want to stand up. You guys are okay? Great. So that's how we got into vertebral body tethering. We had a lot of patients, a lot of whom had been fused, parents had been fused. They were looking for options, and we started looking for different options for these kids. There was a whole wealth of preclinical studies. Mo Diab, John Braun, Peter Newton did a whole wealth of studies in the 2000s that showed that certainly in the laboratory, vertebral body tethering had promise. Larry Lenke actually published the first clinical report that I'm aware of the first patient with a vertebral body tether in 2010, published it as a case report in JVJS. 2011, we started doing vertebral body tethering, and it was a very slow ramp up, right? Because we wanted to make sure that we understood what was happening to our earlier patients prior to jumping in full force. Between 11 and 2015, about 10 to 12 sites around the US started taking up vertebral body tethering. And then there I was sitting at my office in late November after we had presented some data at the SRS in 2015, September, and the FDA showed up. And they said, wait a second, this is starting to get much more traction. Stapling never really got traction because, quite honestly, we were pretty quickly able to show that it wasn't efficacious, that there were alternatives. So the FDA comes in and tells us, stop. You're not doing any more surgeries. And we are going to, you've got to make sure you're not publishing on it, you're not presenting on it, because it's off-label promotion. Pretty scary time, actually. I don't know if I was going to be, put into handcuffs and sent off to jail in 2015. As it turned out, it's actually not in the purview of the FDA to dictate clinical practice. And one of my patients who was scheduled for a tether a couple of weeks from the date that they'd come was well connected in DC, and we were able to get tethering restarted, but with a lot of different parameters that had to be met. Got to make sure they're being consented appropriately. Can't be up presenting data on it, and make sure we don't promote it. And then 2015, after the halt, I just want to make sure everybody understands the FDA was really willing to work with us. I'm going to show you the study that in 2019 led to the approval, the HDE, the humanitarian device approval. And at this point now we have over 150 surgeons trained. There's over 50 centers around the world that are performing vertebral body tethering, and over 2,500 patients that actually have been treated. So I'll go through some of what we've learned over the years from tethering, so those of you that have some interest in it don't have to make the same mistakes that we made along the way. So the first question is, who is this indicated for? And this is a growth modulation procedure, so there has to be growth remaining, right? And you can determine this a lot of different ways. You can look at age, you can look at parental height, you can look at menses. What we really rely a lot on is actually the Sanders hand x-ray that gives us an idea of what the growth plates are doing, and we use that to really determine if there's going to be enough growth for growth modulation to occur. In addition, the curves, if you're going to take a 75-degree curvature that's stiff, you're not going to take a little rope that's flexible and be able to correct that, right? So it's got to be a curve that has flexibility in it. And generally, we like the curves to bend under 35 degrees, and the vast majority of our patients have failed bracing. How do we do it? In the thoracic spine, we do it thoracoscopically, 3 15-millimeter incisions. In the posterior axillary line, 3 5-millimeter incisions in the anterior axillary line. In the lumbar spine, I think it is much better to do an open retroperitoneal approach and really peel the psoas back. When we've tried to go trans-psoas, we've had lumbar plexus issues. And this is what it ends up looking like at the end. And here I have a short video. Let's see if I can get this. Maybe we can play this. Basically, what you're seeing, the patient's head is to your right, the legs are to your left. We're in the front of the spine. You can see the lungs. We're taking the pleura down right now, right along the rib heads. We've taken the segmentals, and we have not to date seen an issue with taking segmentals with respect to neuromonitoring. Once the segmentals are taken, we put in our stapling anchors, followed by our tethering screws that get placed. We typically will start proximally, T5, and work our way distally. And we're doing all of this under direct fluoroscopic guidance. Once the screws are in, we go ahead and introduce the tether, and then gradually, segment by segment, we're trying to compress the convexity, trying to put the Hutter-Volkmann principles into play, compression to inhibit growth, offload the concavity so the growth can catch up. And sure enough, what we see is growth modulation in a certain number of patients. Pre-op, 6 months, you can see over time the spine is correcting. And there's a little video here, and we get these videos sent from our patients not uncommonly. Maybe we can hit that play button. And yes, patient is doing great, right? Wow, vertebral body tethering. You got a speaker up here who's already told you he's got some bias and some confounders, who's telling you how great this is, right? Of course, we have to be much more critical. I know Dave Skaggs and Sig Burv and everyone's like, come on, Amer. Where are the long-term studies? What about tether breakages? Do I really care if there's motion in the thoracic spine? And how does it fare with respect to posterior spinal fusion? These are great questions. These are questions we ask ourselves, right? We want to know, how are we doing? And if we don't, then we're going to let a whole subset of patients get treated. And I saw that a little bit on a much smaller scale with stapling. So I'm actually even more cognizant of this. And if you PubMed vertebral body tethering, there's been 15 papers that have been published in the last couple of months. The literature is exploding. A lot of this occurred after the HDE approval came into place. If you did a PubMed search in 2019, 3 or 4 articles. We had a couple of them. If you do a PubMed search today, go back, you're going to see 15 articles. People are looking at pulmonary function. They're looking at motion. They're looking at early results. Late results, really not in right now. Perioperative complications. And in an overall gist of these articles, and we're going to go through a couple of these, the data are favorable, but it's still early, right? If you're doing growth modulation, if you've got a child, just like Sig said, a parent's trusting you with their child, you don't want to see data when they're 14 years old. You want to see when they're 18 years old. You want 20 years old and 25 years old. And that's going to take time for us to get, but we have to be very critical as we go through understanding where this works and where it does not work. At the Scoliosis Research Society meeting, there's 12 accepted papers this year. So again, this is a very hot topic in our space. What I think is going to end up happening is much like with any new technology, a lot of excitement. We're going to recognize where the limitations are, and then we're going to end up at a steady state. And maybe I'll try my best to share where we've ended up with vertebral body tethering, because without a doubt, for some patients, the results are spectacular. But there are a number of patients where we have to do better. And we'll try to walk through what those patients are. So, getting back to this timeline slide, so August 2019, the FDA gives us an HDE approval. And, earlier on, it may have sounded like I was being a bit disparaging toward the FDA. Absolutely not. That's their job. They have to protect patients, right? And they were actually very willing to work with us to get this device approved. When you see the study that was done, there's very few devices that would get some sort of approval based off of this study that we conducted at our hospital. This was presented at SRS and then subsequently published in JBJS. And basically, what they allowed us to do, they allowed us to take our patients that we'd already operated on, so it was a combination retro with a prospective component. They brought the patients back, so we had patients that met our criteria, 30 to 65 degrees, thoracic curvatures, and we collected data till they were 18 years of age. So they allow us to bring them back, and the key thing, and something that I really implore you, anytime you see a tethering study, make sure you recognize who's reading those x-rays. Because let me tell you something, when I read those x-rays, for some reason those numbers are a little bit better than when an independent, and that was very important. And in this study, we had an independent vendor go ahead and read this. And obviously it was through the FDA, that's very important. So what did we find? 57 patients, not surprisingly, mostly female. They were mostly no menses, and you can see the Risser and the Sanders here. So essentially, skeletally immature patients. Our follow-up was pretty good, right? We almost hit 5 years. That study's continued even after this publication, and we are well past 5 years at this point. And you can see age at most recent study for this paper was 17. So essentially, we did get them, the vast majority of them, to skeletal maturity. Operatively, 7.5 levels tethered. Our duration of surgery, I can tell you today for a thoracic tether, the operative time is probably about 2 hours or so. Obviously, with the learning curve, we have improved there. Mean blood loss of about 100 cc's. There were a couple of kids where we hit the segmental that needed blood, so it does happen. But obviously, with experience, we've gotten better there. And then days in the ICU, length of stay, you can see there. So looking at the coronal plane, and again, this study, we had patients that had smaller curvatures. Today, the minimum curve would be 40 degrees. And one of the reasons why we've seen overcorrection is because early on we were doing these young kids with small curves. But in this paper, 40 degrees, first directive 19. At 24 months, we're down to about 14 degrees. Perhaps there's some growth modulation going on. And then you see this bounce back, and I'm going to come back to that bounce back a little bit later in my talk. And you see the proximal curves and the lumbar curves. We took 30 degrees as if you're less than 30 degrees at skeletal maturity, most of the natural history studies would say you're unlikely to progress. So we took that as a parameter of success. And in our cohort, it was 80% of the patients were less than 30 degrees. The other paper, Dan Hornschmeyer, Feroz Mianji, it's a very similar number, 74 or 75 degrees. The sagittal plane, of course, we got adult surgeons here, very important, but this is a 2-dimensional measurement here in a patient that has a 3-dimensional issue, right? You have rotation. So we're doing this study in 3D. I would say that, certainly we didn't see that we were decreasing it, but with tethering, you just don't want to hit the extremes in the coronal plane or the sagittal plane. I thought being in the front of the spine, with rigid, severe lordosis, it just doesn't do well, okay? So you want to stay with the moderate curvatures. So here's another paper. So that was our paper, and now there's been a slew of papers. So Dan Hornschmeyer, he looked at a vast variety. So we looked at the lanky 1A, B thoracic curve patterns. Dan now looked at the whole slew of curve patterns, smaller number of patients, also published in JBJS, 29 skeletally immature patients. He had some double tethers as well. And as you can see here, the results, if you look at them, fairly similar. About 50% of correction. There may be some growth modulation that occurs over time, and 74% less than 30 degrees. But we don't want to just talk about the positive results, right? There are some results that really question this, and I give Peter Newton a lot of credit because he published and presented this in 2016, subsequently published in JBJS. He took 17 consecutive patients, and what he showed was that there was a revision rate of about 50% in that cohort. The thing I really want you to note here is in his study, 16 out of the 17 patients had open triradial cartilages, meaning a lot of growth. And growth can get you, as we know, if you're doing pediatric spine, growth can get you, particularly with tethering. So there's likely going to be this growth spot. So I told you there had this sweet spot. I told you that there has to be growth remaining. If you have too much growth, you have the kid that has the triradiate open patient, that patient's too young. I try to delay that patient whenever possible. This patient right here, who's a Sanders 4 and a Risser 1, 12 years old, that's the ideal patient. And then the Risser 5 Sanders 8, in my mind, doesn't really have a role for vertebral body type. That patient's mature. You have a great option for that patient on the right. You can do a nice thoracic fusion here. We went ahead and then started looking at our numbers broader, right? We don't want to just focus in on the Lenke 1 curves. We had 83 patients, both thoracic and lumbar curves, that hit skeletal maturity. We presented this at SRS. The paper's been submitted to JBJS. And here you can see main thoracic curve comb angles now 48 degrees, because now we're including all of our patients that were coming through, not just the patients that had been for the IDE study. First erect 22 degrees, 2 years 15 degrees, and then you can see, again, there's this bounce back that occurs. And again, we'll talk about that. That's going to be from tether breakages. But this is the slide that I want to spend some time on, because if I stand up here and start showing you all the great results, we want to look at where can we improve, because there's room for improvement. There was 22% reoperation rate. The highest number was overcorrection, okay? And some of this is going to be patient selection. You take a kid, triradiate open, you tether them, good chance they're going to overcorrect. And some of this is going to be technical, and I'm going to cover both of those. And then there are some that added on, because if you got to, again, you got to pick your levels correctly, and then there are a few that have gone on to fusion. That number here reads around 4%. It'll probably be 5 or 6% that are going to go ahead and get fusion. We're going to present that actually at SRS this year, our cohort that went on to fusion and what our results were. So reoperations, overcorrection is the number one reason, okay? As I stated, triradiates open. Undercorrection, there were times when patients would come to our to our office. We practice near another practice that's probably about 50 miles away that does tether, that does not do fusions anymore. And it's a cash-only practice. I'm just being very honest with you. Patients would come in and they'd say, look, Dr. Samdani, if you don't do this, we're going to mortgage the house, or we're going to do a fundraiser to go ahead and get this done. And wrongfully, especially now, and we're looking at in retrospect, some emotions would tug on us and we would do them. Those patients, it does not work. It's too stiff. Don't do that curvature. Curve doesn't bend under 35 degrees, probably not going to be a good option. And here's just an example of overcorrection. As you can see here, take a mild curvature, you correct it too much, triradiates are open, they're going to go ahead and overcorrect and likely require a tether to be cut. So I get asked this a lot, who is your ideal first patient? And remember, ideal first patient is very different than ideal patient. Ideal patient is where motion's going to matter. It's going to be in the lumbar spine as far as I'm concerned, or in the thoracic spine in a kid that truly needs that level of motion there. But for those of you that are thinking about it, the first patient would be a thoracic, moderate flexible curvature. Don't have too much rotation, because technically that adds some complexity. Be aware of the C curve pattern. If it's a C curve pattern, I almost always try to do a selective thoracic fusion. Lumbar, like I stated, bigger impact, but definitely technically it's going to be more demanding. And pick the right patient with respect to the family and with respect to growth remaining. But it's really not about picking the ideal. It's important to stick to your parameters, but it's much more important, and perhaps where we have the most difficulty, or it's going to take a lot of time to get data on, is how much to correct the spine, right? Because you're trying to predict growth. None of us have a crystal ball. Families ask me all the time, how tall is my child going to be? We don't have that crystal ball. We look at a lot of different parameters, because you want to try to dial in how much correction you're going to put in. Try to dial it in with respect to how much growth you have remaining. And that's really what's probably the most experience-based overall. And essentially, we try to compress across the apex, but try to leave the ends loose. We did understand, so early on, we had all these overcorrections, as you saw in my data, so we started undercorrecting. And then we said, wait a second, if you undercorrect and you don't get the curve, we're going to present this at SRS this year, if you don't get the curve under 35 degrees, it's not getting back under 35 degrees, right? You have too much coronal and rotational deformity, you're not going to drive it towards correction. So you have to balance it of getting it straightened up, 35, 30 degrees, with how much growth that patient has left. But don't undercorrect. That's a mistake we have certainly made. Alrighty, so again, be cognizant when you're in the operating room, what they're gonna look like intra-op, as you see here, is gonna be very different than when they stand up. There is some give to the tether. So that adds another layer of complexity, right? I mean, it's great with a fusion, you get them balanced, you get them straight, you know when they stand up, they're gonna look good. But here, when they stand up, you're gonna see this give in the tether, as you see here, of 10 degrees or so. Noel Larson just published a paper on this, and that's been our experience as well. Here's a technical mistake we made early on. So you can see we've overcorrected this. Do you see how it's already compressed on the convexity? This has been overcorrected. We should have left slack, and sure enough, over the span of a couple of years, the child overcorrects. Of course, a physician's daughter here. So now she's 3 years after release. We go back in and we cut it, and she ended up doing okay. So here I'm just going to show you a quick video, if we can hit this, of how the cord comes in and how important it is, what are some steps that we take to really try to leave slack in, because it's not as simple as it can be, because the tether itself, it's hard to create some slack. So what we do is we go ahead, and you see here we're capturing our tether screws, we're working our way down distally. We know as we get lower down, we're going to want to leave some slack. And there's a couple of ways you can do this. You can take the tulip, right? If you turn the tulip 90 degrees, you have the tether in, and you tighten the set screw, and you've got it 90 degrees out of your sagittal plane. When you turn it back in the sagittal plane, all that distance is going to go ahead and create a loop. Or you can do it as you're going to see us do here, where you can, as you're working your way down, you're going to be able to create a loop by cutting the tether. I found it to be a little bit easier when we're trying to create a loop. It makes it a little easier to handle. We'll go ahead and cut it, create a loop, and prevent it. So even if it looks like this in the operating room, if they're slack in, they're gonna do better. So, we've done over 600 procedures in the last 10 years. There's 3 of us, right, that operate. We actually say no to more patients than we say yes to. But even with that experience, I mean, look at this. I had this child here, ZH, right? So had a 55-degree curvature. Was starting to get a little bit perhaps into the lumbar spine here. Thought I would leave, maybe 15 degrees of curvature on the table, leave her about a 30 or 35 degrees of curvature when she first stood up. And, felt pretty good. And here she is, she comes in, and at 1 year, man, she looks great, right? I'm pretty happy, the family's happy, but of course, I'm actually miserable because she is still very small, right? And that's what makes it hard. Because even with all the experience, and again, it's really hard to dial in. I thought I had done everything and I would do this procedure pretty similarly, because if I don't correct it, then I know it's not going to go towards that. And that's really the piece that we have to try to work out. And, Stefan Perron and others, we're doing some predictive analytics to really try to figure this out. Now, what happens here, what I've told them is, listen, we're at some point going to have to cut that tether. And then how about mature patients? And just out of curiosity, anybody hear of tethering in mature patients here? Okay, well, there is, again, a group or some groups that are doing tethering in mature patients. I'm just gonna keep it pretty simple. I mean, this is taken from some websites. Again, anytime you have a financial interest, or you can be questioned, and you got to put data out, and I encourage them to put data out so we can see what the data looks like. But I would strongly recommend not tethering mature patients. Otherwise, you're going to be getting a couple of surgeries 6 months apart. There's going to be scarring, and really strongly discourage. What we would recommend is, you see a patient such as this here, we would recommend a selective thoracic fusion every single time. And I think that patient just overall long-term is going to have a better outcome. So, just going back to our coronal plane follow-up, as you can see at most recent, there's this bounce back, right? Some modulation, this bounce back. That's going to be because eventually this is a mechanical device that's flexible. It is going to be prone to breakages, and it's not uncommon. Peter Newton, 47% in his work. Dan Hornschmeyer, 48%. That's pretty similar to what we see. The vast majority, not all, the vast majority will not be clinically significant, as you see here. And here's just a patient that we had, who progressed fairly rapidly. We went ahead and did a T6 to L2 tether. And here she is 6 months later, she grows. And if you take a close look, you can see between L1 and L2, those screws have splayed. That tether has broken, but the outcome is still acceptable, okay? What I see is, if the growth modulation at that level does not occur prior to the mechanical device break-in, you're going to see splaying of the screws. And that's why the growth piece is going to be important. So what are some tips for breakages? They can be difficult to pick up. Typically greater than a 5-degree change in angulation, we get concerned. I have mostly seen in the lumbar spine and lower thoracic, but others report it, across apices and a little higher up. And maybe it has to do with screw alignment or BMI. I can tell you that if you don't align your screws, as you see here, you're already, in fact, I think I already put a little break in that tether already, right? Because that's not lined up. Where you want it is you want it to be lined up, otherwise they're gonna be more prone to breaking. The FDA indications are for idiopathic. Perhaps there's other diagnoses that may benefit more. This is a patient with a low-level myelomeningocele. She needs more trunk motion. Did her about 5 years ago. You can see progressive curvature. As you know, they've got their myeloscar in the back. Risks are pretty high. The curve is borderline, but I felt for her, given her diagnoses, not unreasonable. And we ended up tethering her, and here she is about 5 years out, still has a curvature, but overall, maybe that patient, tethering suits better than our other patients. And lastly, I just want to finish up with why we consider growth modulation and motion, right? Because that's really the crux of what we're trying to get at. Because hypothetically, we're keeping a spine mobile. And as we know, like I showed you that video, I'm sure Dave gets a bunch of videos from his patients who've had fusions done. And they're golfing, they're swimming, they may even be doing some poses such as this. So how can we really take a look and see how the tether compares? And that's been a big drive of ours. Here we go. So we put our patients through motion analysis. We just submitted this work to JBJS. We have over 225 patients that have motion analysis, both with tethers and with fusion. You can see a wealth of data. My partner Josh Pays is really leading this effort, doing a great job with us. We run them through the motion analysis lab. And let's see. And what you see is, not surprisingly, above L1, there isn't really much of a difference. There is some difference in extension, but as you move your way down, there's a big difference as you get to L3 and as you get to L4. So what's our approach? Here's an 11-year-old pre-menarche, triradiates closing. Our approach, and they really want a tether. The right operation is going to be a selective thoracic fusion. Now, let me see if I can. And over time, you're going to see some correction. And yes, not perfect, but in my opinion, this is definitely the right operation for the majority of the patients. Not all of them. There are some patients that I do think tethering in the thoracic wouldn't be unreasonable. Sorry, my pointer is struggling a little. Whereas compare this to the thoracolumbar curvature, this is where one of the areas that we're really focusing in on. You've got a 12-year-old boy, triradiates closing, you see these curvatures, and this is the kid that I think, really where tethering can shine, and I think he's about 5 or 6 years out now. So trying to avoid lower lumbar fusion whenever possible. So in summary, we want to really try to decrease what you're seeing there, right? Posterior spinal fusion where the tether did not work or break, they didn't grow enough. Predictive analytics, growth assessment, tether materials are all going to be very helpful. We want to make sure we have a better understanding of pulmonary function, right? Understanding the second time you go back in, what are you doing with pulmonary function? We've looked at this, certainly in our IDE study. The results looked reasonable. There wasn't a decline, but something I'm very closely following. We got to recognize that thoracic fusion remains the gold standard. And of course, we're going to have to optimize the indications and the technique for lumbar tether. I'm going to stop it there. Thank you very much.